My colleagues and I found evidence of a potent interaction between a common blood thinner and some diabetes drugs. The use of warfarin was positively associated with serious hypoglycemic events among people who were treating their type 2 diabetes with either glipizide or glimepiride. These are commonly used medications in what's known as the sulfonylurea class. And specifically, the risk of hypoglycemia, that is insulin shock, severe enough to warrant an emergency department visit or even a hospital admission, was more than 20% higher when people were using both of these drugs at the same time. Hypoglycemia can also lead to falls and fractures and also to mental confusion. We found elevated risk of those outcomes as well with concurrent use. A key implication is that for this population that needs both drugs, careful monitoring, very careful monitoring by both physicians and patients is going to be important. Why should one care about this general topic? Well, 3 out of 10 Americans, elderly Americans, have diabetes, and 7 out of 10 have multiple chronic conditions, including stroke and atrial fibrillation, which are treated by warfarin. Each year in the United States, nearly 265,000 hospitalizations result from adverse drug events, such as accidental overdose, and almost 40% of these are due to either anti-diabetic medicines or anticoagulant medicines. Warfarin itself is known to interact with many drugs and foods, and clinical references used by clinicians raise a hypothesis that warfarin enhances the hypoglycemic effect of glipizide and glimepiride. But there's really been no hard evidence to date. So what we did was we looked at elderly patients treated in the Medicare program, the U.S. program for people over 65, with diabetes over 2006 to 2011. And we focused on calendar quarters in which these people filled a prescription for either glipizide or glimepiride. And we then compared rates of our outcomes between quarters in which the individuals also filled a prescription for warfarin to quarters in which they did not. The key findings were the risk of hospitalization for hypoglycemia was about 20% higher, and that's after accounting for patient age and sex and comorbidities. That association was most pronounced among people who are just starting warfarin therapy when the appropriate dose is fairly uncertain, and also among folks who are 65 to 74 years old, a relatively young elderly population for whom concerns about warfarin have been less pronounced to date. In terms of the other outcomes, fall-related fractures were more than 45% more likely when warfarin was used concurrently, while mental confusion, altered mental status was about 20% more likely. So what are the implications? Well, we have an opportunity here to improve population health while avoiding costly hospitalizations. Hospital admission for hypoglycemia runs more than $20,000. An admission for a fall, more than $12,000. So for this population that needs these drugs, what's needed is careful monitoring by physicians as well as patients, particularly when starting warfarin therapy and perhaps when otherwise modifying therapy. It's worth noting that the Medicare program currently does not cover the cost of continuous glucose monitoring for people with diabetes. And this research raises a question as to whether such coverage might be cost effective for the program.